Neil ended the last session with a comment. As I recall, he said the customers are not the customers. What he was talking about is something that Simon raised, I think, in one of his early questions this morning. We've had a lot of discussion about the various stakeholders in this broad ecosystem of public-private partnerships. But in this session, we're going to focus on a particular part of that ecosystem, which is perhaps the real customers, the users of the technology, which not only includes the community health workers, but also the patients themselves, and how we move from a process where we have been pushing technology solutions out to the communities and to the programs to one in which they become empowered and actually guide and pull what they want, what they need, and what they value to improve their own health. And so we're going to talk. We have a great panel this afternoon, and we're going to let them describe their experience and lessons learned in this area. But we're going to start first with Dr. Christoph Pimmer, who I think, Christoph, can you hear us?
I can hear you. Hello, good evening from Switzerland.
Thank you for joining us from Switzerland. Christoph is at the School of Business in Basel, and if you look at your reference list, you'll see that half of the references on that list are from Christoph. So he's a very productive and well-known person in this field, and so we look forward to his comments. In just a moment, we'll let him go first. Next to me is Adele Waugaman from USAID. Next to her is Larissa, who's a Fulbright scholar based in the UK and Sweden. And next to her is KP Yelpaala, who is the CEO of Access Mobile. And so we're going to get a broad perspective from each of them about their views and their experience on engaging the real customer and empowering the real customer to create a pull from the communities and from the patients for these technologies. So with that, why don't we begin, Christoph, and let you take the lead on the next discussion.
Okay, yeah, thanks, Barbara, for the very charming introduction. I very much wish I could be able to join you in person.
Christoph, I'm sorry. Are you muted?
Can you hear me now? Can you hear me?
Yeah, just when we're starting.
Good timing.
Murphy's Law.
Can you?
Do we have any IT experts in this?
So.
There we go. Thank you. Good.
Okay, cool. So again, thanks, Bob, for the very charming introduction. I very much wish I could be able to join you in person. I have seen several familiar faces here. However, I'm very pleased to be able to contribute in a virtual manner. And I like to begin perhaps by outlining a bit the framework of my presentation. I'm very much focused on the role that mobile social media can play in supporting health professionals. So I'm a bit on the community side, but very much focusing on health workers and community health workers. And in terms of media, I think I will concentrate on a very particular, let's say, subset of digital media, namely on social mobile media, which includes, of course, social networking, particularly Facebook, which we all know, of course, and also instant messaging or mobile instant messaging, which is perfectly epitomized by WhatsApp. And both of these tools are increasingly available on mobile phones, and they are also increasingly popular in global health context. So in the following, I will shorten this to social mobile media. So the different formats of mobile social media, they can be actually classified within a spectrum that has two opposite ends, which are firstly small and bounded groups or closed user groups, as we can call them as well. Typically, we can imagine a group of health workers on a WhatsApp group, And the opposite pole is large and nearly boundaryless networks. Could be, for example, centered on specific Facebook sites, and we have seen that with up to tens of thousands of health workers. So, of course, the reality is not as clear-cut as this, so there are many in-between modalities as well. And one of the main differences between, let's say, instant messaging and social networking is certainly accessibility. So instant messaging tools, particularly WhatsApp, are very simple, and they have feature, in particular, the exchange of audio messages, which also make them accessible for people with, let's say, lower levels of literacy. And they are hugely popular in all of our projects and in many other projects that I have evaluated. But just to give you an example, in almost all of our projects that we run currently with nurses and health workers in Zambia, South Africa, and Nigeria, they're already using WhatsApp. And Facebook tends to be a bit more restricted and not so much available still at the bottom of the pyramid, if you like so. There are, let me change that. I will quickly try to outline key functions that mobile social media can take and can have for health professionals, for health workers. There are at least 4 dimensions, I would say, which are social, knowledge-related, organizational, and political. I will begin with the social dimension, which is very much centered around professional connectedness. And connectedness as such may not sound particularly exciting, but when we take a look at contexts which, for example, according to the World Health Organization, are marked by professional isolation, which can in turn lead to attrition and to health workers, community health workers, and nurses also who leave their profession. So in this respect, social media can connect distributed health workers in ways not previously possible. And one example is that we studied a Facebook site which was founded just by one Nepalese medical doctor, and he did this completely independently. So his engagement was not tied to any organization. And this bottom-up site was visited by tens of thousands of doctors and medical students, not just from Nepal, but from across Asia, with, I think, about 1,500 interactions per week, where the visitors, the medical students, the doctors, and other health professionals shared all kinds of experience, discussing professional identities, roles, values, concrete procedures, medical questions, and so on. Another example comes from a current study that we've carried out in Nigeria, and there we found that yet the informal, non-guided, non-orchestrated use of WhatsApp by Nigerian nurse students during their placements was associated with lower levels of professional isolation, and on the other hand side, by higher levels of professional social capital. So, interestingly, so in addition to connectedness, in almost all social mobile media spaces, we find some forms of formal or informal knowledge exchange, and informal knowledge exchange and learning is particularly common, for example, in groups or teams of health workers, community health workers, or nurses. I have many examples here who use and open up social mobile media spaces to support each other, engaging in joint problem solving and in knowledge exchange. Just to make it a bit more tangible, in one of our South African studies, we found that the nurses who were working there in quite rural areas, they used a closed Facebook group to consult each other when they were facing more difficult patient cases. And of course, such examples are indicative to using social mobile media more systematically, also in more formal training and learning settings. And this can be achieved in different ways. For example, in South Africa, we have use the closed Facebook groups to teach and coach rural nurses and midwives, and this has worked surprisingly well. So, of course, social mobile media spaces, they are not better in terms of their functional repertoire than specific learning platforms, but their distinguishing feature is accessibility, which means that in many, many contexts, these tools are already in the hands of health professionals. For example, in South Africa, in this study, we observed that in case of technological problems, the nurses were asking their children or their neighbors' children to help them with WhatsApp or with Facebook. And this can make troubleshooting from a technological perspective, of course, much easier. Good. Another dimension is organizational. So health workforce, particularly community health workers, they are quite often distributed in geographical space, and they're very hard to reach and to manage. And in these contexts, so social mobile media spaces allow, and actually, and interestingly, for the first time in history, a mobile and flexible many-to-many communication. And this very much helps to organize them also complex work or more complex work issues in very often a quicker way. And this is, for example, something that I have observed in a recent study with community health workers in rural communities in Malawi. And they started using WhatsApp groups to organize campaigns or meetings or the distribution of drugs where more than one health worker was involved. And things turned out to be much quicker than before, where there was kind of a linear communication process in place. And finally, I think there's also another very interesting dimension, the political dimension, which means that mobile social media are and they can be also used by health workers, also by the communities, to accumulate and to exercise power. And again, the thing is that the geographical distribution gives health workers and also the communities very little opportunities to organize themselves, whereas joint social media spaces can be exactly used for such purposes. And I think I just give you one example, which was quite impressive and which was reported in The Lancet from Taiwan, where about 1,500 Taiwanese emergency department staff started to voice concern about poor processes and other problems regarding their work in the emergency departments in a Facebook group. And within weeks, they triggered quite a stunning multi-party dialogue with very different stakeholders, including the health ministry, and even the health minister was part at some point in time and discussed things. And in this way, they managed really to break up hierarchical boundaries in ways not possible before. Let me very quickly try to position social mobile media in the digital land healthscape, very cursory, of course. Many of today's mobile health or digital health tools are actually geared towards capturing structured health information, structured health data, which is of course very helpful, particularly for central health authorities who then aggregate and further process this information. But I think that the complementary role that social mobile media can take here is to offer opportunities for a more flexible, a less structured communication, in particular among collectives and groups or networks of health workers involving communities, because in some projects already communities are being involved. Let me conclude by saying that the massive adoption patterns of mobile social media that we see already now, and they will further increase in the future, they mean that even if we are not convinced to leverage it to harness these technologies systematically in our own health projects, we cannot actually ignore them any longer, because health professionals, health workers, increasingly communities are using them anyway. And this has a number of positive, but also very clearly negative implications that we need to address, and only some of which would include digital professionalism, the economics of participation, questions regarding regulation and information quality. Yeah, I think these things will certainly pop up in the discussion that we have. I guess there will be some more times to dig a bit deeper. And yeah, so in the next slide, some reading materials, and finally links to more information about my work. But I think this is enough for the introductory presentation. Thanks for now, and back to you.
Thank you, Christoph, and thank you in particular for reminding me, which is something I've begun to forget, that social media can be a very positive, constructive force in the world. So with that, let me move to Adele.
Great, thank you. All right, hi everyone. Being 3 days shy of 40 weeks pregnant on a panel called Push versus Pull, I feel like I'm really tempting fate. But I was excited to come and be part of this discussion, and I also figured there'd be some doctors in the room. Although hopefully I won't need to call on anyone. But if I make a sudden dramatic exit, apologies in advance. So as Bob mentioned, my name is Adele Waugaman. I am a senior digital health advisor in the USAID Global Health Bureau. And in this role, I've been brought in to work with the Global Health Bureau to think about how we can be doing more to overcome some of the fragmentation and duplication that we've heard a lot about today and that we all know is a big challenge, particularly for the public health decision makers at the country level. So it's been really wonderful to hear from Shupo and Alvin and Leslie Ann and so many others who are working on trying to bring together this coordination. And so what I want to do today is talk a little bit about the value proposition for digital, specifically for enabling this pull of information up, or if you're looking at it from the community or customer perspective, a push of information up from the local level up to central decision makers, up to central ministries, international organizations, and how digital technology can enable this, and where it does enable this, what kind of qualitative differences we see in the way that health data and information flow. So to ground this presentation, I'll be talking about some research that Larissa and I had the opportunity to undertake together between 2014 and 2016, when I was a consultant for the USAID Global Development Lab, and Larissa was a AAAS fellow, also working with the USAID Global Development Lab. And we looked at how data and information flows were moving in the West Africa Ebola outbreak response, and where digital technologies were being used, what kind of differences did we see. So we interviewed altogether about 130 people representing 60 organizations, and put together a report that's now available online. It's called Fighting Ebola with Information. For those of you online who would like to look at it, you can use the bit.ly link, bit.ly/Ebola report. So one of the things that digitized data often does, that we, I think, hear about commonly, is that it makes data more readily accessible, oftentimes in a higher quality, and in a more timely manner. And of course, that timeliness was really key in the context of the Ebola outbreak, when you had a disease that was moving incredibly rapidly. And we heard anecdotally some cases through our interviews that, for example, in Liberia, there were cases in which the process by which it took to move case reporting data from paper into a digitized system, into an aggregated report that would then get published through a situation report that was the weekly status of here's where we are in the Ebola outbreak, here's how many cases we have, was sometimes up to 3 weeks behind the actual reality of what was happening on the ground. And that's a really significant delay. So that increase of timeliness of data is really critical. But one of the things that we were most interested in, and I'm forgetting about my slides here, was how the integration of digital technologies enabled qualitative differences in the response. And so we looked specifically at a few different examples. As Christoph mentioned, one of the main things we saw was that there was a huge increase in the plurality of actors engaged when there was digitization of data and information flows. So we saw examples of citizens and frontline health workers communicating directly with health ministries, communicating directly with NGOs, in ways that just weren't possible at scale without that digitization of data. We also saw an increased directionality of data and information flows. So whereas With paper-based case records, for example, the data was primarily moving in one direction up for aggregation and decision-making. Where digital technologies were integrated, we saw the information moving back down. And this was really critical in the context of health workers, for example. So you have health workers, I think Neil mentioned the black box, people reporting data and information into a black box. They don't ever hear back, they don't know who's using it, how it's being used. But when you have digitization of information, such as between frontline health workers and ministries, where information is moving in both directions, it creates this opportunity to enable ministries to report back to the health worker, thank you for updating us on the recent case count in your district. Are you aware that in the adjacent district, the case count has risen? And that gives the health worker actionable information that they can use to best prepare themselves for the response. So I'll give a couple of concrete examples from the report. The first is the mHero project. The mHero project is something that was run by IntraHealth, supported by USAID and other partners, working in close collaboration with the Ministry of Health in Liberia. And this was really an interesting case, including because it was a technology that was piloted during a crisis, which is normally not what you want to do. You want to be using the technologies that are tried and trusted, but it was integrating a number of systems that were already at scale, including the IRIS Human Resources Information System, the Rapid Pro SMS bulk text messaging program, and was effectively able to knit together, to interoperate these two different systems in a meaningful way to enable the Liberian Health Ministry to communicate directly with its remote workforce. And this was critical, in particular in the early phases of the response. The health workforce had really dispersed and scattered. There were many health workers who were abandoning their posts, who had fallen ill, who otherwise were not reporting for duty. And in order for the Ministry of Health to understand where its assets were and to leverage its assets, it needed to know where the health workers were currently reporting for work, what level of training they had, potentially also what kind of equipment they had at their station, and setting up this direct real-time communications between health workers and the Ministry of Health enabled them to do that. A really fascinating footnote about this project is that even though it was piloted during a crisis, it's still being used widely today, and in fact, it's part of the 2017 to 2021 Liberian Ministry of Health Digital Health Strategy, which is fantastic. It's really the gold standard for uptake and standardization, so that's a very positive sign. Another example from the report is the Ebola Community Action Platform. This was a project in which there were a number of different NGOs that were using digitized data and information that they were collecting via mobile phone, oftentimes basic feature phones, about the community knowledge, attitudes, and perceptions of Ebola. And this was critical data for informing the social mobilization response, which of course we know was really important to stemming the tide of Ebola. We needed to understand what people thought about Ebola, how their behaviors might be contributing to the spread of Ebola, and then being able to communicate to people to let them know how to best be able to care for themselves and their loved ones. So there were approximately 2 million people in over 3,000 communities across Liberia that were reached through this program that was led by over 800 social mobilizers, so it was really quite at scale. Using phones with the Open Data Kit software and using the WhatsApp peer-to-peer group messaging app. And ECAP, the program, took this data that was coming in from all over the country and aggregated it in a platform that was made publicly available so that all organizations who were involved in the Ebola response, who were interested in understanding how current understanding of the Ebola outbreak should be leveraged in developing behavior change communications, were able to use it. And so in that way, the community data was pushed up from the community level up to higher levels for use. Another example is the They Say program in Liberia that was run by an NGO called Internews. They used an interesting combination of both digital and non-digital media. So they created a short code, a short phone number that people can send text messages to, and asked people, are you hearing rumors about Ebola in your community? If so, send a text message to this number and let us know what that rumor is so we can address it. And they got in information from around the country about rumors, which contributed significantly, particularly in the early days of the crisis, to the spread of the disease. And once they had that information, they shared it with local broadcast journalists. who were able to, in turn, bring in locally recognized and trusted experts who could then debunk the myth. And that role of trust, of locally respected and recognized authorities who could address misinformation was really critical. And so this was a fascinating example for many different reasons. So now that we've talked through some of these concrete examples of how digitized data was used in the response, I'll shift gears a little bit and talk about what difference this made. So first is that this digitized data and the diversified information and data flows that it enabled created new incentives in the response. So going back to the example of the Ebola Community Action Platform, or the ECAP project, we heard from social mobilizers that one of the biggest incentives for them to go into often difficult and dangerous environments was that they had this peer-to-peer messaging platform through WhatsApp to hear from other people who were doing similar work and to get encouraged by their peers to continue to do this dangerous work because it was important for their countrymen and countrywomen. And that they reported, it was sort of an unintended and unanticipated outcome of the integration of technology, that they got this peer support that was really critical to them, you know, in some cases even more so than getting paid to go into these dangerous situations to do their jobs. We also heard about new insights. So again, another example from a program that used WhatsApp was the United Methodist Church. Its clergy already were using WhatsApp to communicate with one another prior to the outbreak. And when the outbreak happened, that became a major theme of discussion. And there was one particular incident in Sierra Leone where a local clergy member identified that a woman who likely was an Ebola patient was being transferred to a clinic that was unprepared to treat her. And so he was able to message somebody else through the WhatsApp platform and say, this likely is about to happen, and this unprepared clinic may be presented with an Ebola patient. Can you please help reroute her to a clinic that is appropriately prepared to treat her? And they were able to do so. We also saw an increase in the rise in accountability. So in Guinea, for example, the use of GPS-enabled smartphones to collect contact tracing data inserted the location of the contact tracing visit. And in an environment in which there was understandably a lot of fear about going into the houses of people who were either suspected or known to have had Ebola, this created an additional layer of transparency around the collection of data. And I should add that it also creates transparency at the managerial level as well, because if you see data is not coming in or there's a problem with the data, if managers are able to see this in near real time or in real time, they have an obligation or an opportunity to try to correct the problem. And finally, we saw a rise in adaptive management, so the use of real-time data to improve programming. And I think the social mobilization and behavior change example, such as the ECAP program I talked about, is a great example that really illustrates how you can leverage real-time data to improve programming in a way that makes the programming more directly relevant in the field. So each of these is, I think, a really important qualitative distinction that the integration of digital technologies can bring, including by kind of empowering this push of information up from the local level, push up from customers to those who need to be better attuned to and more aware of what those needs are, if that's indeed our aim, for example, as a development agency. But it's not just a just add water type solution. There are a number of different supporting and corollary investments that need to be made in order to enable the effective integration of digital technologies. And I'll turn it over to Larissa to talk a bit more about that.
Thank you, Adele. Larissa?
So we're tag teaming here. I'm really pleased to be able to be here today to present this research. It's actually the first time that Adele and I have been in the same location and able to talk about the report. So she's given you a sense of some of what's in there, and so I'm going to likewise draw from that, but focus more on the issue of data, which has been a theme this afternoon, obviously also throughout the day, and talk about some of our recommendations. I'll talk in particular about the Ebola case data, which is one example of data that moved kind of upwards. So it was not necessarily, it was generated at the community level, but due to reporting requirements from above. First, I want to, as Adele mentioned, much of the Ebola data were collected on paper, and the information flow was via word of mouth, analog or paper-based channels. This is a picture from the Sierra Leone Ministry of Health from February, and what you see here are boxes of rumors that were collected during the Ebola outbreak, and it gives you a sense of kind of how much information was being passed. In terms of the case data, what does that mean to have data that are collected on paper? As we mentioned, it moved up for decision making. They were collected at various points. Case information were collected in health facilities, in communities, and moved upwards to the national coordination centers. The paper forms that were used to document individual case data were lengthy. The case investigation forms that were used primarily to they were derived to collect epidemiological data and to conduct epidemiological research about Ebola, because we knew very little about the disease when it began. These were about 10 pages long. So if you think about that, each one of those, cases had to be manually transferred from a case, and then they were collected on paper, and then they had to be digitized. It was eventually condensed to 3 pages, but if you think about Liberia at the peak of the crisis that had approximately 500 cases per week, that's generating 5,000 pages of information that needs to be digitized and updated every single week. So you can understand, you get a sense of why the data were about 3 weeks behind in terms of reporting and digitization. So obviously, as the case data moved up to the national coordination bodies, they were aggregated for decision making. And these aggregated accounts of the case data were released in situation reports or SITREPs, and they were published in PDF format. But obviously, the choice of publishing format really mattered. The decision to release these data, which made sense at the time, they were producing PDFs, but the fact that they were not machine readable in these PDFs meant that they were not easily accessible for other purposes, such as translating some of those data into dashboards for disease modeling or for forecasting analyses, just to name a few examples. Data were collected via different platforms. Mostly for NGOs, it was via Excel, which the late Hans Rosling referred to as the workhorse of the Ebola outbreak. But some of the NGOs and others that were operating treatment centers actually had electronic data collection as well. But then this raised questions about how do you keep data that were collected in a hot zone? How do you keep that in the hot zone? How do you maintain any kinds of electronic equipment that is in that hot zone? And then how do you decontaminate it when it's brought outside? For the outbreak as a whole, EpiInfo, or and in particular the viral hemorrhagic fever module, was used in Sierra Leone and Guinea, but in Liberia, the caseload data were eventually collected via DHIS2. Another characteristic was multiple reporting streams. Case data were collected via routine disease surveillance, but also via the Ebola-specific disease reporting. So you had these multiple streams that were collecting virtually the same data, but these data then were housed in different silos of information collection. And as I think Leslie Ann mentioned earlier, there was a proliferation of tools, of systems that were used or deployed often for the first time during the response, including some of the ones that we feature in the report. And when you combine that with the lack of common standards or data sharing protocols, this really complicated the compilation and aggregation of data across systems and actors. Separate from these issues, in terms of the case data recording and sharing, we also found inconsistencies in terminology that were used to describe Ebola. So the definitions of the primary categories of suspected, probable, and confirmed differed slightly across the countries, which is not surprising because the responses themselves were run by the national governments, and so that does make a lot of sense. But when you're dealing with a regional outbreak and you have these slight inconsistencies, it means that aggregating across the countries became more difficult. You also had definitions that changed over the course of the epidemic. At one point, it was fever and 3 additional symptoms. Later on, it was just a fever. And if you had a fever, you were a probable, I believe, case of Ebola, and so that did change over time. And those definitions and the changes were not well or consistently communicated across the range of actors. So this picture here is taken actually by Merrick Schaefer in Liberia in November of 2014. And what you see is a mapping of the information systems, the information collection during the Ebola outbreak. So as you can tell, it was really complicated and difficult. And in a crisis kind of situation, the collection and management of information really is a challenge. So where do we get from all of this? This is a visual from the report that we use to really encapsulate our recommendations. I'm only going to talk about a few of them. But we really, a lot of these echo a lot of the earlier comments from today, such as the need for standards, for coordinated investments in health infrastructure to support digital health, as well as economic and social development. And they range from everything about the user environment to institutional capacity and also investments. So one of the recommendations is to invest in the physical infrastructure needed to extend digital connectivity. So for this audience, that's an obvious recommendation, I think, but here's a visual to support it. Here you have a comparison of cell coverage data for West Africa from 2014, so obviously outdated, but current at the time of the height of the outbreak, and also the environmental suitability for zoonotic disease outbreak. And what you see is in some areas there's a complete lack of cell phone coverage in some of the most suitable areas for zoonotic disease. In Liberia, here's a comparison of cell coverage in Liberia and the location of health facilities. A key issue at the beginning of the outbreak for Ebola and disease reporting was the inability of health workers to report disease because they lacked internet or cell phone coverage, or in some cases top-up funds to actually call the national coordination centers. So you can see in this that there were either many facilities that were without coverage or on the edges of the estimated coverage where it was less reliable. So another one of our recommendations is to conduct baseline surveys that identify the strengths and weaknesses of the digital infrastructure. Things like, is mobile money used in country? What areas of the country have cell phone coverage, and what type of coverage do they have? 2G, 3G, higher. A number of our other recommendations look at not the physical or the digital infrastructure, but really about some of the people and institutional support that are needed. So a key learning of the report is that technology in many ways was the easier part. The technological solutions exist. The harder part is the institutional and the workforce capacity, the policies, processes, and workflows within institutions, and also the data literacy capacity among staff members. And these were oftentimes lacking and impeded both the uptake and use of digital technologies and also data. There was a high need for a specialized cadre of data scientists, of data visualization and data analysis experts. And on the institutional side, there was a need for updated policies, processes, and workflows to respond to needs that were introduced by the introduction of and integration of digital technologies. So while data and technologies may solve some problems, they also create new ones. In some cases, the introduction of new systems caused delays and introduced additional confusion into an already chaotic environment. When you had new definitions that were communicated, you also got shorter forms, but both of these required paper-based and training for both paper-based and digital systems, so that increased those needs. You also had system-wide improvements that occurred, but they required that there were people present in country who could maintain those digital systems. And this goes back to a point that I was thinking about from this morning's discussion, and that is the importance of understanding the context within which data are collected and used. We're generating more and more data in part because we are we're able to do that, and we're able to do that more quickly, but we don't necessarily understand the cultural, social, and behavioral issues that either promote or prevent the use of data or even of digital. It's both a physical context issue, but also about social aspects, whether or not people trust the information source. As we learned in the report, trusted messengers are absolutely crucial, as are things like the ability to collect data in both online and offline environments. So data visualization really helps to promote data use, but too many dashboards containing information that doesn't respond to the specific needs of responders aren't necessarily helpful. So a final set of recommendations is related to the need for coordinated investments in digital health, but also to support the development of common standards, both on technical aspects, but also on the content side, so that data can be shared and compared. And if we have time in the Q&A, I'm happy to talk more about that. So there was a lot that we learned in conducting this study about the use of data and information, but as one interviewee said, it's only when we can act on these lessons that we can consider them truly learned. So in that way, we have a ways to go. Thanks.
Thank you, Larissa. KP?
Great. So I think we'll have a video coming up.
Okay.
Yeah.
So while we're waiting for the video to come up, we can begin to think about your questions after KP has a chance to make his presentation.
Many of the EMR solutions that we are trying to use in Africa really cost a lot of money, and it is very difficult for the users to adapt to this technology.
At Access Mobile, we understand the value of patient engagement in driving the quality of healthcare.
AM Health allows for basic practice management and patient engagement through mobile phones in one simple and easy to use web and mobile platform. They can manage their queue, they can track payments, they can send appointment confirmation and reminders. In one simple tool, they can define their whole digital approach to engaging patients and managing their practice.
Nakasi's domiciliary clinic is a community-based clinic established to provide quality health services to the people of Wood. Immunization is among our recurring activity. We find that our clients end up losing their immunization records. We even end up losing follow-ups to our patients. But with AMLF, it has helped us to maintain good data and information system to the clinic and making a good follow-up to our clients.
Clinic yasindikira message okunzijukiza ogemesa omwana wange ekyo kindaga nti omusawo afaayo eri obulamu bw'omwana wange.
So AMLF has eased our communication system between the management of the clinic and even our patients and the clients at all.
Our records before have been paper-based. We used to write from the reception to the prescription. We are happy to have AM Health on board because as a doctor, I get my appointment on time, also reduce the waiting time for the patients, and we could reach around 3,000 patients by a click of a button. They feel more satisfied because they see it's a one-on-one interaction with the doctor. Having this digital platform on board will help us give quality care to the patients.
AMULT is a health NGO. We provide HIV treatment. We treat about 1,200 patients on a monthly basis.
Before AM Health came into our clinic, we had a lot of difficulties tracing our clients. There was quite a huge expense trying to call them or even to text the clients using the numbers that were available. But once this system came in place, it has really made our work a lot easier. It has helped us in a cheap way access these clients who are otherwise labeled lost to follow-up. We have seen our service uptake in the clinic go up as much as between 15 and 20% in the last 3 months. 99% now are able to come for their clinic appointments on schedule. The first people to give us feedback were the clients themselves. They were really excited. This system is keeping them updated on how to take their drugs, their clinic schedules.
Our platform has grown and we now engage health consumers directly through GOZI. We are creating a holistic platform that can impact patients and providers.
GOZI is a web-based application where a patient can log in and search for the right healthcare that he wants. The person can search for a doctor's name, you can search for a clinic, and from GOZI directly you can also book an appointment through mHealth.
Gold Star Network is a program that is a social franchise where we have networked over 250 private providers in Kenya. One of the challenges that our clients have is to identify where the clinics are located because we do not have these clinics easily recognizable as HIV clinics. GOZI is playing a very important role in assisting our clients wherever they are in the country to be able to obtain the list of Gold Star Network clinics for their HIV services.
AM Health, to me, is a transformative digital health solution. This is a system that is going to take healthcare services in Kenya a notch higher.
These products are really going to help in making the clinics get nearer and become more visible.
It was cutting-edge technology to me. It was easy to use, it was practical, and it was affordable. I believe this is a well-thought-through solution. It will mean a lot to healthcare players of all sizes, but more importantly, for the patient. they will be able to actually engage with the provider and change the behavior in terms of from a healthcare perspective.
Great, thanks for that. Yeah, I'll be brief. So I thought it'd be nice to give you some context. Let's not forget who we're serving and the clinics that we want to impact as well. So I'm just gonna be brief because I know there's the Q&A has been really engaging. And first what I wanna start with is talk about.
This is Karen Hospital, Town Clinic Branch.
Let's have gone to the next one. So first I wanna talk about, let me give some context for why I founded Access Mobile. What I observed, so I started Access Mobile in 2011. I'm a public health practitioner. I worked on national scale public health implementation in Ghana and also in East Africa as an early employee of the Clinton Health Access Initiative. So I come from an implementation background, not a technology one. It was clear, particularly working and living in East Africa, the digital transformation was happening, was going to play an important role in improving access to and the quality of healthcare services. Everybody was talking about pilots, too many pilots. And my hypothesis at the time was that I believed there were a lot of pilots because the funding for mHealth was driven through projects. And so if the funding associated with the digital health innovation is attached to a 5-year project, then my hypothesis was that at the end of that 5-year project, naturally the solution might end in its life cycle. So with Access Mobile, I decided that for this experiment, we wanted to build a digital health company driven through private investment where we could look to engage with communities and the private health sector directly on a value basis to see if we could build solutions that they would pay for from a value perspective and that also would, at the end, kind of at the beneficiary level, also benefit patients. Through that, we could build a business model of paying clients and then work ourselves to the patient, as you've seen in GOSI, where now we start to find ways through mobile, whether it's SMS or light touch apps, to now get the patient engaged. Knowing that people typically do not pay for apps, a free app business model in Africa would not be one that would be, in my opinion, justifying of in private investment. So we thought we had to start with the provider first. So that gives some context for this. And what you've seen is where we are today, about 6 years later. The first thing I want to frame quickly is that the digital health landscape is shifting dramatically across African countries because the digital landscape is shifting. When I started the company, we would think SMS would be the only way that you could really engage somebody. That is no longer the case. If you see some of the statistics here, we find that more and more people have smartphones. More and more mobile internet access is expanding. And Africa as a continent is demographically young. So if we think about millennials and the generation to follow millennials, they are plugged into social media. And we have to think about all these channels as we think about how to engage. Our approach was really about listening, learning, and evolving because that's what you do when you're a business. Customers are brutal. If you don't offer value to a customer, they won't pay you. If they won't pay you, you have no business. So by nature of our model from the beginning, we had to be centered around wherever we were trying to create value. And that, to me, we talk about it as bottom-up innovation. In our field, people can talk about it. People use different terminology. We can talk about it as community participatory approaches. But at the end of the day, you start by asking a few key questions, which I've listed here. And by making sure that value is aligned to some of these points. So are you addressing a large pain point that users want it fixed? Are the people we want to impact have many things going on in their life? We are concerned about their health, but that is one point of reference for that person. And so the issue is how do you as someone that's trying to influence them, get inside and get their attention, right? You have to be thinking about a large enough pain point for that individual. You need to build always with the end user in mind and where they're coming from. Simplify, we've heard this theme throughout the conference. Get feedback early and build feedback loops. This is how you iterate and how you learn. So in essence, the pull mechanism for your solution becomes a co-creation process, right? Because if you want to drive adoption wherever you want to drive it, and the group or the person that you're creating value for, you're listening to, they will basically help teach you how to create value for them, right? And in that co-learning process, that creates the pull, okay? And then we have to think about incentives and feedback loops as well. So if we're dealing with an individual who has a lot of things going on in their life, they live in a community. In that same community, there's an agricultural initiative, there's a water and sanitation initiative, there's an HIV/AIDS initiative, and probably all of us are hitting them with 50 texts a day about all those different things. At some point, they might just tune off, right? How do we get their attention in the right way and in the context of their life? If we just removed Access Mobile from the center here, really we're centered around the patient. So I mean, that's really what our solution suite is trying to do. And we talk about these principles of practicality, affordability, and usability. One thing I want to point out in the context of public-private partnerships is we're a growth stage organization. So because of the model that we use to find our path, we raise private money from friends and families, friend and family members, and then a Series A investment. We are now scaling. So we've gotten to about 150 hospitals and clinics on our platform, 2 million patients, around 100 to 200,000 messages a month related to someone's health, driving some impact. We're now scaling to around 400 facilities this year in the region. One of the things that we found to be important as a small organization that's growing is the need for private-private partnerships between small companies that are growing and maybe teenage businesses, as you've mentioned, or bigger companies that have the wherewithal and the infrastructure to help an organization like mine in the right way. And I think that we've found that working with some of the bigger private corporations, there are challenges with how they adapt to us as a smaller, high-growth organization. We do believe that if we can get those synergies between us and a private-private dynamic, that now allows us to think about public-private partnerships, right? So then, you know, smaller organizations that are innovators partner with bigger organizations and then approach the ministries in a position of more, that would instill more confidence in the public sector that those organizations are ready to scale. I've just listed a few of the themes here. I think a lot of them have come up, but I'm sure in Q&A we'll discuss further. Thank you.
Thanks, KP. Let's see, we have some burning questions. Yes, in the back. Please identify yourself.
Youngjijo from Johns Hopkins School of Public Health. I wonder if you could talk a little bit more about user characteristic. And also, my second question is a potential concern in terms of equity point of view. So if the system is built in a way to respond to the kind of push signal of demand, then especially in the context of a disease outbreak, what about, you know, I mean, like people who doesn't have that tools that cannot give that kind of signal? Thanks.
Would you like to take that?
On this one? Well, on user characteristics, maybe. I think that what's clear, if you look at any ecosystem, there's no one-size-fits-all solution. So if you think about your beneficiaries or end users in clusters, then you think about what's the best way to engage, for example, or communicate with that cluster. And for us, for example, we leverage a lot of open source technology. I mean, we're not really looking to reinvent the wheel. So, you know, Neil's mentioned Twilio. There's all kinds of actors out there where you can leverage their infrastructure. But then I think you have to be thoughtful about the endpoint and what's the best way to communicate. And so for us as a solutions provider, when we build our solutions, we think about it that way. So if we're coming to you as a group, we need to be able to offer you the flexibility. Is SMS the right channel? Is WhatsApp the right channel? Is Messenger the right channel? If it's a good solution, at some point they should be able to give you that flexibility and say, well, based on the target beneficiaries, let's figure out the right model. So that's at least how we approach it.
So one of the things that Ted talked about is building the road and then having others build the cars and the rest of the infrastructure necessary. One thing that it was interesting hearing two different models for how to leverage IT. In the first case, we heard from Christoph and from Adele and from Larissa about almost organically how some of these benefits came up. I mean, you gave them the phones, you gave them social media tools, but a lot of what developed that was valuable to the community was actually organically developed. I mean, they encouraged each other, the incentivization, supporting each other. In the Ebola outbreak, examples of how social media, led to knowledge exchange, that sort of thing. So my question really is about, and then in KP's case, a little bit more of a structured approach for delivering IT, and then finding ways to build in responses from the community and how you optimize that delivery. I wonder how much of this has to be organic to work, and how much of it needs to be more strategically incentivized. And I'm thinking particularly about community health workers, who often aren't paid, who obviously need the kind of organic support that they're obviously going out and getting what they need because no one else is providing it to them. But can we think about pay for performance? Can we think about professionalism? I think Christoph talked about that. Things that we could leverage social media and IT for that would be a little more of a strategic, more long-term approach to how we empower community health workers and even patients and how to use this. I wonder if, Christoph, would you like to comment on that?
Yeah, no, I try. I think this is quite a key question because community health workers, they are very important, and I think they need the support, as you mentioned already, the most. But unfortunately, they are already perhaps the last to get the technology and to get the systems running. However, what I observed that particular WhatsApp is in reach, so we have to differentiate, but I think this is we are quite close that instant messaging and mobile instant messaging can be accessed already in some contexts and will be in the hands of many more community health workers in the future. But I think the challenge already starts when you go into a particular context, because I quite often hear something like, what we need is kind of a WhatsApp, but especially for health workers. And I think this is how it's not going to work in many cases. So because the success of these tools lies exactly in their genericness and their broad availability. And I think, and we have heard this already, but I want to reiterate this. First, we have to understand the local practices. We need to draw on and build on our interventions, our processes on existing cultural, but also more and more on technological practices. And what we do in many of our projects is that we go in and examine what people are already doing, what health workers are doing, and to find out what the more innovative health workers are doing, and then help them to locally mainstream their or globally, but their innovations and to push it further. So it's a kind of balancing push and pull. And I think putting local actors in the driving seat is really some of the key aspects. And one of the more interesting examples is from one study from colleagues from K4 Health, Johns Hopkins Bloomberg School of Public Health. And for example, what they did to really get the local actors driving the social mobile media engagement, they asked the local leaders who identified the key stakeholders, if you like so, and they asked them, we won't set up anything, so choose the media, and then you set up the space, and you invite your colleagues, your work colleagues, and so on, and you drive them, and you ask your colleagues to invite their colleagues and so on. And the interesting thing is that within 9 months, I think they got 10,000 of health workers in one group, which is really fascinating. And I think we can learn quite much from influencer marketing. So really try to identify local influencers and make them support, or not even support, make them drive these activities. Once you have such a space, I think a key aspect is not to destroy it, because in many projects I've seen that people are inclined to say, okay, we're using social media, but we leave the social things out. This is for content, this is for topic only. And I think then these spaces are very quickly to be abandoned. And so managing the social and the topical pole is one other key task in that. And you talked already about the constraints of social media, and I think in more fully leveraging mobile social media or social media, I think we need to more systematically address those. And I already said, regardless of whether they're using these spaces or not, what health workers, health professionals, but also health institutions what they require is a more systematic guidance of how to use such tools in a responsible and also, of course, in a critical way. Because, for example, we have studies saying that most of the clinical content on social network sites and others is not according to clinical guidelines. So there is a certain gap and a certain challenge to be addressed. Yeah, so there are many more aspects. One, what I would like to stress in particular, is also to help health workers who will use WhatsApp and Facebook, regardless of whether their organization is like motivating them to do so, in developing a digital professionalism. And this is not just how to use those tools in a let's say in a technical way, but this is really about how to use these tools according to ethic guidelines. There are many tricky things all in the broad use of social media, but we cannot hide because they will come anyway.
Yeah, well, thank you, Adele.
Okay.
Add to that, I mean, you talked about accountability, adaptive management. I don't think you were implying they were unintended, maybe unexpected consequences of putting the system in place. Are there other things we could be doing to further empower the health workers, not just the program managers?
Sure, yeah. I mean, I think part of it is this is a mindset shift that's required among organizations that are used to being data miners and data consumers and the ultimate authorities on data. And there was a great quote from somebody in the Library and Ministry of Health who, in watching the mHero program evolve, said, we really have a tremendous opportunity now to begin to devolve some of the decision making. And if we can figure out how to effectively share information back to the source, contextualize this information with other data that adds additional value and share it back to the source, we're going to better empower our frontline health workers to be more efficient and effective eyes and ears in the field for us, but also more efficient healthcare providers if they're empowered with that kind of data. But when you move from an environment, as was the case in the 3 most affected countries in West Africa by the Ebola outbreak, where you largely have a culture of data gathering and consumption and sharing that's paper-based, it's an entirely different environment with totally different possibilities than one in a digitized environment. And so there was a lot of quick thinking in the Ministry of Health about how can we adapt to best be able to leverage this opportunity, to best be able to empower our health workforce. But the reality is that kind of a culture shift takes time.
Yeah, that's really important. When you think about the next Ebola epidemic, just like all of them in the past, are not going to be first detected by Hopkins people in the field or CDC or public health. It's going to be community health workers. They have to be incentivized to participate, not just to wait for a question, but actually to contribute to the system. So that's going to be a tough challenge, isn't it? I think we had a question over here in the back. Yep.
Incentivize organic growing. So these examples on the Ebola catastrophe, they are very interesting, but we have to remember that it's only one of the public health challenges that we have when we talk about catastrophes, actually. And one of the characteristics of a biological catastrophe is that it leaves in place the physical infrastructure, right? So there is, on the top of the challenge of making good use of what we already have, we have also to take into account that part of the infrastructure in another sort of catastrophes like earthquakes, like tsunamis, and that are public health challenges as well, we have to think on that. So actually we wrote a paper on the mobile phones, and catastrophes, and the role that you need to have on redundant systems as well, right? So do not trust only on what you have for the common daily life, right? Because these will be brought down in a catastrophe. So you have to have, and in this way I think that it's important to incentivize the redundant, systems like amateur radios, and other sort of nets that you can implement through Wi-Fi and all of that. So this was mine.
Well, we have 2 minutes left, so what I'd like to do is just, and to wrap up, just pose a question to each of you to quickly answer. So, one of the things that we've heard a little bit about is a lot of innovation in this space has come from the middle and lower income settings where there's less legacy systems and a lot of opportunity, not just challenges, to try things new. It occurs to me that, particularly in the context of NCD's discussion earlier today, we're in a society in the United States moving to move the point of care out, away from facilities. The point of care and the point of need are moving further away from the Western model. The irony is this is the way medicine's been practiced in these communities in Liberia and Uganda and Ethiopia and India for many years, relying on community health workers. So in some ways, there's an opportunity to leverage what's already out there in more effective ways and maybe come up with some new solutions, not only to manage Ebola, but also perhaps chronic diseases using the community, using the point of care and the point of need where it already exists. And we're going to need technology to do that. So my question for each of you is, do you have a single top recommendation for how we can better leverage the community-based care model, which is what we see in most of the communities we work? How we can leverage technology, and what's your number one recommendation for how to do that? Let's start with KP.
Wow. So I think that our point of view is that if you look at, so I'm just going to focus on underserved populations globally. If you look at the characteristics of underserved populations globally and NCDs, they look similar all around the world in terms of the drivers of morbidity and mortality. And so I think, my point of view is that, like in our model, we've been able to build our technologies without some of the legacy systems and regulatory constraints you find in the Western models.
But do you have one recommendation based on your lessons learned?
And I think that the solutions can come back into the Western context, but with the right partners. So it's still a different context, the way the health system works here. So can the technologies work? Yes. Is the context different? Yes.
Great, thank you. Larissa, what's your number one lesson learned or recommendation?
Yeah, I would sort of build off of what JP just said and say, understanding the context is absolutely crucial. And that gets to everything from, establishing those redundant systems and using, multiple ways of communicating, not just the digital tech.
Let's go to Christoph and then we'll finish with Adele.
Yeah, first I agree fully on what has been said, and I think in addition I want to reiterate some point, because I think the development of digital professionalism needs to be embedded in the training, in the education of community health workers, of health workers, of professionals. I think this is really key, because this is a complex issue. You cannot do it you cannot count that they will learn it on their own. So I think this is something that I would recommend from a more strategic perspective.
Thank you. And Adele, you get the last word.
So I would add, I guess just to circle back to my last point, that for large donor organizations and NGOs, we need to learn how to listen differently. I think we've always been interested in listening, and this is a new kind of listening we need to do from a larger audience that's communicating in new ways, and tie that back to the customer through adaptive programming.
Excellent. So let's join me in thanking our guests. Thank you very, very much. Christoph, thank you.
Thank you.